I'm Melissa Barnett, very pleased to be joined by my good friend John. We work with many companies to grow our wonderful profession. Please, let's continue this conversation about keratoconus and everything else. And we have a lot of information to cover tonight. So this is going to just go fast and furious. And we're so glad that you're here to join us.
Well said, well said. Well, I'll go ahead and start off, jump right into this. So we all know a little bit about keratoconus, right? So keratoconus is really a corneal disease that's characterized by a loss of biomechanical strength. This loss of stromal corneal strength causes focal thinning, steepening, and irregular topography. And it has a variety of different components that cause its manifestation. Those can be genetic, environmental, behavioral, and the typical onset of this is within the pediatric population. So when we talk about keratoconus, we really need to understand the differences in the stromal architecture between a normal cornea and the keratoconic cornea. If we look at the normal cornea is put together by a series of helixes of collagen fibrils, which come together to make microfibrils. Those microfibrils come together to make fibrils, and those fibrils then come together to be bands of lamellae. And the bands of lamellae that we have are densely interwoven in the front of the cornea. And as we go to the back of the cornea is going to be more stacking of those lamellae. If we look at the central cornea from a front view, we can imagine that it is mostly orthogonal in arrangement, kind of like lattice on a pie. And circumferentially around the edges of the cornea, it's interwoven as well, kind of like a bird's nest. So when we look at this, I clearly enjoy pies, bird's nests, and pancakes, but really what we're looking at here is what gives the strength characteristics of the normal dome shape of a cornea. So if we move forward, what we'll see is the various different types of biomechanical measurements that we can do on these corneas. Scarcelli's work looks at Brion microscopy, which is a way to measure photon shift and turn that into corneal strength profiles. What you can see is if you put a point at any point on the, on the normal cornea, we generally have a similar strength profile anywhere across the cornea. Now, Dupes' work works on optical coherence elastography. So what this is putting a little force on the cornea, recording a OCT of the cornea and watching the deformation of the cornea. And what you can do is watch the movement of the keratocytes to infer the strength of the cornea in the front and back of the cornea. And what you can see is in the blue line there and the orange line, in the graph, you can see that the blue line has a much steeper slope than the orange line. And what you're seeing there is the bifurcation of the strength profile of the cornea, the anterior cornea being stronger than the posterior cornea in a depthwise fashion. So if we go to the keratoconic cornea, what we're going to see is changes in the keratoconic stroma. What we see is a loss of insertions of those lamellae in the Bowman's layer. So you can see on the left the normal lamellae inserted into Bowman's, and again that kind of bird's nest interweaving, and the loss of that in the keratoconic cornea. What we also see is a loss of the lamellar density in the area of the cone. So you can see this clearly in Keith Meek's work off to the right. Basically what this is all going to be related to is the decreased natural corneal crosslinks. So if we take a look again at those strength profiles, we can see that the Brion from Scarcelli's work, if we look in the area of the cone, that area is focally weak. But if we're outside of the cone area, we can see that we actually have a more normal strength profile, showing us that keratoconus is a focal weakening. And if we look at the front to back strength, what we see is in Dupes' work off to the right, we can see that in the keratoconic cornea, there in the pink box, the strength profile is homogeneous from the front to the back of the cornea, indicating a loss of that anterior corneal strength. Perfect. So we can visualize this in a method using a high-speed shine flood camera. This is a device available outside of the United States, the Corvus ST. And what we're doing is we're hitting the cornea with a puff of air. So very similar to your NCT or what you might have with a Reichert device in the US. But this is actually shine flow high-speed video, so you can actually watch the deformation of the corneas. What you'll notice is in the normal cornea, it resists the initial force, pops down, holds, and then very quickly recovers. Whereas the keratoconic eye, when it gets hit with its air puff, deforms very rapidly, sits and oscillates and jostles for a bit, and then takes a very syrupy recovery compared to the normal cornea.
So that's all just amazing information. And I like to bring it back to your practice and your clinical practice because not all of us have all the toys that John has in his practice. But those are fantastic images. But how often do you see keratoconus? And I'd like you to think about that. You can put it in the chat if you want to. But in our practices, we see keratoconus every day and many, many patients every day who have keratoconus. So we know it's really that posterior cornea that we're looking at. And we have tomography where we can image that posterior cornea and find the irregularity. We know that there's an abnormal global thickness variation. So not just focal, not taking pachymetry in one spot, it's looking at the entire cornea. And we know it's that non-inflammatory corneal thinning. As John showed the picture before, it could be in different areas, and we will show you some different types of keratoconus and some different images coming right up. But good news, keratoconus awareness is growing. We still have so much potential for growth. However, as you can see here, there are different news stories about keratoconus. Tomorrow is World Keratoconus Day. I'm wishing all of my patients a happy World Keratoconus Day. I hope you are too. But it's a good way to educate and to celebrate keratoconus and really to diagnose early. We hope that from tonight's presentation, you will take home the importance of diagnosing keratoconus early, managing early to prevent vision loss and to keep vision for the entire life of a person. So how prevalent is keratoconus, John? What studies do you look at? So we've all heard that 1 in 2,000 study that was out there. And then if you look at all these different studies, and I will focus here on the global meta-analysis, keratoconus is actually more prevalent than we think. Now, I work in a few different locations. One does not have all the fancy equipment, and we're picking up keratoconus because I believe, and I'm sure you do too, John, is that we really need to rule out keratoconus in every single person. So just like dry eye disease, we need to evaluate every patient for dry eye disease. We also need to evaluate every single person for keratoconus, especially in children. So there's a great study that IKA and ICO has done and showed, and this is screening children, just all children in an inner city population, showing the prevalence of 1 in 352. Now, why is this done and why is it so high? It's the method of screening. So really, if you go back to all these studies, you have to look at how patients were evaluated. What type of technology was used in order to evaluate them to diagnose keratoconus? And in this study, corneal tomography was used, and you can see that prevalence. Now, John, do you think that prevalence, do you think that number is high? Do you think it's low? What do you think about that?
Well, it's significantly higher than what anybody had previously had. And in the US, this is a very unique study being associated with the School of Optometry and being a broad observational study. Every individual that went into that pediatric clinic was screened as part of a entry exam. And when you look at that number, that's telling us that if we think that we are seeing individuals that are down around 1 in 2,000, we're seeing a significant amount of keratoconus, and this becomes even more important in the context of our interest in myopia management and stopping progressive axial length elongation. These individuals, it may be easy to miss this and chalk it up to increases in myopia, when in fact those individuals do actually have early onsets of keratoconus, and we could treat them and prevent their disease and their vision loss.
So do you think this is the future of screening all children for keratoconus?
Yeah, I really think that, this was really will be a seminal paper when it comes out, but this will really support the use of advanced technology to screen individuals even at their youngest age. Essentially, if you can sit for the screening, you should have it done.
So we know that there are many risk factors for keratoconus. So age, we see keratoconus progress much more rapidly in children. Genetics is a huge issue, and we will show a bunch of studies coming right up for genetics and also family history. So very important to anyone who has a family history of keratoconus to screen all family members, children, cousins, making sure that everyone has an eye examination with imaging, and now we have genetic testing as well. There are many different conditions that are comorbid conditions in keratoconus. So very commonly, allergies, atopy, eye rubbing, and it's not just the really gentle eye rubbing, it's the vigorous eye rubbing. It's the patient that you see in the corner, the child of the patient with keratoconus who's rubbing their eye, then you just die, oh yeah, they have keratoconus right there. But we also need to look at other things like Down syndrome, sleep apnea, really common. What I've been doing is actually evaluating my patients, looking at them from across the room. I think you can look at their eyelids and sort of pick out those who are prone to sleep apnea and floppy eyelid syndrome. Pregnancy, we don't talk about that a lot, but that's really important when we're talking about keratoconus and also progression. And you can see that there are many collagen vascular diseases, much about prolapse. So there are many different conditions that put us on higher alert to be aware of keratoconus.
Yeah, one of the things that you want to really screen for is patients with Down syndrome. If we look at the risk on these individuals, they have a 622% increased risk for keratoconus compared to the normal population. So when we look at this, just screen your patients who have Down syndrome with a corneal topographer. And yeah, it's a very, very high yield on that.
So really everyone who has Down syndrome should have an eye exam with imaging. And as we know, in the pediatric population, the incidence is 1 in 2,000, not the prevalence there. But keratoconus in children is far more aggressive. So you can think of it like myopia. If a child is myopic, it's likely going to get worse. It depends on how quickly it's going to get worse. And of course, that's why we have so many different myopia management options. But in keratoconus, the severity of keratoconus is probably going to get a lot worse and very, very quickly. So that's why we really want to diagnose children very early and treat them early as well.
Yeah, when you look at the CLEX study, for instance, the CLEX study reported a association with individuals who were going to undergo corneal transplants. And what they found was a diagnosis of keratoconus at a younger age was more highly associated with the risk of undergoing corneal transplant. So the younger you diagnose it, the more severe it's likely to get.
The importance of cross-linking early, right? and avoiding a corneal transplant. I'm still shocked now with my patients who are relatively young, who have had corneal transplants, even multiple corneal transplants, and they're maybe in their 20s or 30s. So we now have the ability, and you'll see some studies coming up there. But let's talk about pregnancy and keratoconus. So this was a case-controlled report of 22 patients with bilateral keratoconus. 11 intended to become pregnant, 11 did not intend to become pregnant. And this looked at refractive error and topographies prior to pregnancy, during the 3rd trimester, and then 6 months later, and really showed that those patients who became pregnant progressed. So when we're talking about stabilizing the cornea, and this is sometimes a difficult conversation. However, I talk to my female patients of childbearing age, and I actually say, I'm just asking you this question because you're a female childbearing age, but we want to be on the lookout and really stabilize that cornea in those patients who are going to get pregnant, and it does show that after childbirth that the cornea does not return to the state beforehand. And very interesting, just talking to different patients about this, it's not really out there, and so that's why we want to include it in tonight's lecture, that if you have a patient who has keratoconus and they're female childbearing age, you really want to stabilize that cornea as soon as you can. So moving on to the economic impact of keratoconus, and I love this statistic, which is really so sad, but the expected value of the lifetime cost of treatment of keratoconus over myopia is more than $25,000. And you look at various studies, and they do vary a little bit, but the cost is really high. The cost could be for, say, medically necessary contact lenses and devices and exams and things like that. But this is a tremendous cost, not only to patients, providers, payers, but I tie it all back into the quality of life that is so important for our patients with keratoconus. And let's talk about the quality of life. So there are many different studies on quality of life and the changes in quality of life in people with keratoconus. We actually did a review at UC Davis looking at this as well. And our sort of what we came up with is that, yes, keratoconus is associated with that significantly impaired quality of life that tends to decline over time, but sometimes it's based on that timing of diagnosis. So say it's a child who's in their teenage years and they're doing everything that other teenagers are doing, and then they're smacked with this diagnosis of keratoconus. That is the timing of it that can really affect quality of life. And fortunately, there are many studies that show the benefits of specialty lenses, especially scleral lenses, to improve quality of life in patients with keratoconus. And I'll put a plug in here for the National Keratoconus Foundation, even though we're going to talk about it later. But there's so many great resources for people with keratoconus and beyond just their eye health, but jobs and networking. And it is just a really fantastic resource. So check it out if any of you haven't seen the NKCF. Now, vision-related quality of life is worse in patients with keratoconus, so we really want to take this quality of life very seriously. We do want to have a lot of empathy for our patients with keratoconus and hear their story. You know, my patients come in, I want to know what they've tried, what has worked, what hasn't worked. If it's a new diagnosis of keratoconus, really explaining, giving resources, explaining, you know, that yes, you do have keratoconus, but no, you're not going to need a corneal transplant. We do have other options to stabilize your eyes, and you're going to be able to do whatever you want to do during your entire life.
Yeah, I think the most striking on that list that we just saw was the differences in quality of mental health between normal and keratoconic individuals. It's 67% versus 98%. It's a giant disparity between those individuals, and that brings up the importance of psychological care for these individuals. Melissa, how do you typically handle, the challenges that come along with these patients and the unique challenges of the mental aspects?
Well, I think I really just try to help each person, each patient, and some patients are, you know, they're maybe in the denial stage, others are in the acceptance stage, some are angry. I mean, they have a right to be angry. So I want to make sure that all my patients have someone that they can talk to, that they feel supported. Oftentimes, we're managing with many different specialists. They're seeing a corneal specialist and me, and I want to make sure that their primary care doctor's involved, or if they have cardiology, but also psychology, a psychologist or a psychiatrist, if they want that. So, and that's where the National Keratoconus Foundation comes in, because I like to give that resource, because sometimes it's nice to have a resource outside of my practice that can help patients in so many different ways. What
Yes.
about you?
Agreed, agreed. The ability to, have somebody that, you can recommend to your patients, and it's not, it can be a slightly difficult conversation where you bring up the mental health aspects of this, but I always just bring it up to everybody and just give the, I know this can be a very tough diagnosis, and some individuals can have a pretty tough time with this. If you feel like you would like, consultation with a mental health specialist, they are there to help. So, yeah, so they have the,
Where I work, we can put in referrals, so that's really nice and helpful.
that does help. Excellent. So when we get into kind of traditional management of keratoconus, we remember that, diagnosis was really made when we had subjective complaints and observable findings that we could see, obviously Myers and, thinning of the cornea, Voxtria, Fleisch's ring, all those sorts of things. What we would then do is visually manage the individual with a corneal gas perm, but we had no interventions to actually stop the disease. So as those individuals, if they did continue to progress, they may progress to a point where they had contact lens intolerance or complications, or they may have advanced corneal scarring from things like eye drops. Those individuals who had a decreased ability to wear lenses or a decreased ability to be corrected with their vision would often be left with the last treatment for them, which is a penetrating keratoplasty. If you look at the rates of penetrating keratoplasty, Tufts reported, this is back in 1994, so these numbers are going to change when we talk about them later. But in 1994, about 21% of his keratoconic group underwent keratoconus. So 1 in 5 individuals would undergo penetrating keratoplasty. Now on the other side, so Tufts is an ophthalmologist at Moorfields. If we look at the CLEX study group, this is a group of skilled contact lens fitters that are predominantly across the United States, and their rate is about 12%. So really, when you look at that disparity, it is the difference between successful contact lens wear versus individuals who are referred to a center for keratoconic care. So when we look at this, there's a little bit of a disparity, but the real number is probably somewhere in the middle there. So really what we want to do with keratoconus is we want to prevent it from getting really bad and try to keep individuals in the kind of mild to moderate stage. And that's where the impact of corneal collagen cross-linking comes in. So the cross-linking procedure really fundamentally changes the way that we manage keratoconus everywhere. And the purpose of this procedure is to halt the progression of the disease and freeze the disease in place so that we don't continue to lose vision. The idea here is halt progression and save vision. So the modern management really hinges on the ability to diagnose these individuals as early as possible, stop progression with corneal collagen cross-linking, improve their vision with either surgical procedures or specialty contact lenses, or sometimes both, and go ahead and continuously monitor those individuals for changes. Almost think of it like how you would monitor individuals for glaucoma or any other progressive retinal disease that we continuously work with. And to keep our DULCs and penetrating keratoplasties as a treatment of last resort for these individuals.
So what if you're in practice and you don't have any of the fancy toys? And so these are things that we need to be looking out for in all of our patients. So during a refraction, if the vision is not a crisp and clear 20/20, it's kind of a weak 20/20, a guessing 20/20. If there's blurry vision, shadows in vision, a poor quality of vision, and frequent changes in glasses or contact lens prescriptions, an increase in astigmatism, an increase in myopia, refractive shifts. And so this is something I'm looking for in all my patients. If you have a keratometer, if you don't have a corneal topographer or tomographer, but you have a keratometer, I would encourage you to actually look and check keratometry in all of your patients who have astigmatism. We also want to look at the axis of the astigmatism. If there's an asymmetric asymmetry between the eyes, if there's more astigmatism in one eye versus another eye. And if you're finding these things like irregular Meyers, and we do this on autokeratometry, you can look for irregular Meyers, then please send your patient to have imaging done. And you might want to send them out if you don't have it, but I would encourage you definitely to do more testing if you're suspicious for keratoconus. So here you can see some Meyers that are quite irregular. If there are steep corneal curvatures over 47, if there's an abnormal contour, of course, if there are any signs, scarring, stria, etc. But we do want to be looking out for keratoconus in all of our patients. Now, here is a study looking at retinoscopy compared to a pentacam, and basically it showed that retinoscopy is quite sensitive and specific and can be a very reliable test to detect keratoconus. And I'm bringing this up because I think that we all need to be looking for keratoconus in all of our patients. Now, fortunately, there is some technology that can be used in practice that's at a lower price point, and I hope that we can actually get corneal tomography at a lower price point globally so that we can be looking for keratoconus in all of our patients all over the world. But pull out that retinoscope if you haven't for a while. And here we see all the clinical signs of keratoconus in those advanced cases like John showed us earlier. I love looking at my patients from the side and taking pictures. You can have them look down, you can see Munson sign here, but we don't want our patients to get to this point at all. We really want to diagnose keratoconus early. We want to manage, stabilize that cornea with cross-linking so that they don't develop eye drops or anything like that.
One of the one of the questions that we asked ourselves in our clinic, since we do a tremendous amount of work in keratoconus, what we wanted to see was, in a retrospective review, were there any just basic exam findings that may indicate an individual has keratoconus, or find any trends within these individuals. So we wanted to look at basic exam findings that everybody would be doing during a typical eye exam. So we looked at manifest refraction and autokeratometry, and we related those back to their pentacam measurements and their Kmax values, so their point of steepest curvature of their cornea. So we did this as a retrospective in our clinic, and a pretty large amount of keratoconic eyes on this. We excluded any eye that had had previous surgery, so that excludes about 80% of our eyes. But when we look at this, it's a pretty decent amount, so we got a pretty good cohort here. So if we take a look at the numbers, what you'll find is that when we look at manifest refraction specifically, we find that individuals with keratoconus are predominantly against the rule or oblique in their astigmatism. That comes up as an orientation over or about 80% of individuals. And what we also find is that even in very early keratoconus, we still find about 2 diopters of cylinder being present. And if we go to keratometry, what we'll see is that keratometry additionally is kind of an interesting thing. We looked at auto Ks versus Kmax, and what we found was that using the steep K off of auto Ks was on average 8 diopters less than what we would see on Kmax. So often what this would mean is that we were underdiagnosing keratoconus if we were only looking at K steep. We were missing it. And when we looked at another study on cone locations, what we found was that autokeratometry is taken generally in the central 2 millimeters of the cornea. When we look at where Kmax tends to be, it is significantly outside of that. Over 70% of eyes with keratoconus are outside of that area. But what we also found was in low levels of keratoconus, again, those individuals still had 2 diopters of corneal cyl, again, in the same oblique and against the rule axes. So what we came up with for keratometry was that stim Ks are a poor predictor of keratoconus being present. And if we take a look at kind of our end conclusions here, what we'll see is that essentially you really need to have modern technology to help you diagnose early, because if you're seeing these patients who have a cylinder that is 2 diopters in a against the rule or oblique axis, whether that's on manifest refraction or in your Ks, you should go ahead and test those individuals with a corneal topography.
John, in the study, did you look at the difference between the two eyes in the amount of astigmatism and the keratometry values and this all the pentacam measurements?
So we do have that data, but we haven't reported on it yet. So
Okay,
we're
that'd be
yeah,
interesting.
yeah, it'll be a fun one for sure.
Yes. So I think we've covered the importance of really diagnosing keratoconus early to prevent corneal transplantation, which I think in turn really helps improve quality of life. It also reduces costs for patients and reduces that economic impact. And we talked about the collaborative care as well. So, those patients who have any sort of a family history, I encourage all my patients to bring in their families, everyone to have a full eye exam. Also, we now have genetic testing and we can do imaging on these patients. We want, if you're kind of suspecting keratoconus, we want to avoid eye rubbing. We can treat our patients with topical mast cell stabilizer antihistamines, even if we're suspecting that they might have keratoconus. We can use, sort of environmental tools as well to prevent allergies and eye rubbing. But anyone who has a comorbidity like Down syndrome, or sleep apnea, floppy eyelid syndrome, I would encourage you to screen them for keratoconus. And if you look at the studies that we showed earlier, different ethnicities are much more prone to keratoconus, and so screening those patients as well. So this, oh, and it's a lot easier to fit glasses and contact lenses. I think that that's important. So cross-linking is not a refractive surgery procedure. Many patients think, oh, yes, I'm going to eliminate all my vision correction completely, but the goal here is to stabilize the cornea. And it's much, much easier to fit a patient who's been cross-linked than a patient who has advanced keratoconus.
Excellent. So what we're going to go over now is kind of the metrics that you would use for diagnosing keratoconus with some of those advanced instruments. Now, excuse me, when we look at the metrics that are out there and the various different studies, there are metrics upon metrics upon metrics upon metrics. And there are tons of different devices out there, tons of different papers on them, tons of different algorithms that have been written with different types of sensitivities and different sorts of factors coming in. What we're going to teach you right now is I'm going to teach you the basics of what you need to know looking at any device. This will be, whether you have I'm just going to shout out some brands here, but whether you have a Topcon or a Medmont or an Oculus or an Essilor or any one of those topographers there, you're going to know how to be able to read that scan to diagnose keratoconus. So let's go ahead and jump right in here. These are just images of what's out there from the metrics standpoint. So let's start on topography. So topography really is only evaluating the corneal surface. Basically what we're doing with this is we're projecting light rings onto the cornea, and we're looking at the displacement of those rings from a perfect circle. The more distortion, the more irregular that we're getting of the cornea. So you can see the Myers on the left being the normal cornea, the Myers on the right being the keratoconic cornea. You can see the difference there is that the Myers are warped. We all know this. This is not very, groundbreaking here. But the main thing to note is that tear film anomalies will cause irregularity to Myers, but tear film anomalies are typically causing breaks within the mires rather than having a smooth irregularity. So looking for warped mires is keratoconus. If you're seeing broken mires, those are tear film anomalies because the light is really not being reflected off of the corneal surface, but rather the tear layer that's resting on top of the cornea. Something that makes it nice and shiny. So if we look at the analysis here, you can see the variety of different shapes of keratoconic topographies. So those maps, that spacing can be translated into the colorful maps that you see here. And you can see that there are a variety of different shapes. You can have apical bow ties or apical astigmatism, which can be preclinical keratoconus. You can have more central cones that are in that central, 4 to 6 millimeters. You can have oval cones that are more inferiorly displaced, and you can have more globulous or widespread cones. It's interesting the names that people will give these in the modern era. I literally just watched a lecture where they called them snowman, crab claw. What were the other ones? What was the other one? It wasn't bow tie. They called it something else like present tie or present ribbon and like other things like that. It was pure comedy, but it's actually in a published paper. So essentially, it's just pattern recognition that you need to know is looking at this. But this can get a little dicey because the scaling on each different device can be a little different. So don't entirely rely on, oh, there's a red spot, that's keratoconus, because there are scaling factors that can happen. Like you could normalize a scale and 43 diopters could be bright red and 41 diopters could be bright or dark blue. So pay attention to the metrics and the scaling and the relation to the colors that you see. So if we look at diagnosing this, and you can go ahead and click all those images all the way to the end because lots of animations here. But when we're looking at this, there are well-accepted metrics that have been done mostly by Rabinowitz and Kleiss over the years. And what we're looking at is any K value on the front of the cornea as being 47 diopters or greater. And if we take a look at, sorry, my fellow just texted me because she is watching this right now, and she said, "You forgot duck shaped," and that is actually one of the things that they called it on there. That is hilarious. But yes, so any K value greater than 47 diopters is keratoconus if we have an IS ratio, which is essentially looking at asymmetry from the top to the bottom of the cornea. If we see greater than 1.4 diopters of difference from the top to the bottom of the cornea, that is keratoconus. If we see axis skewing in a normal bow tie astigmatism, we should be able to just draw a straight line and it goes through the apices of the astigmatism. In keratoconus, we'll have some skewing of those apexes. And if we draw lines through those apexes, it'll create an angle like what you see over here. And that skew axis greater than 20 degrees, if you have more than a diopter and a half of corneal astigmatism, is keratoconus. So if you look at the examples here, this is actually a great example for why you don't want to trust stim Ks, is if you look at the central K mean value here, it is 44.5 diopters. That's a very normal number. But if we look at the point of maximum keratometry in the orange circle there, that's 54 diopters, 10 diopters steeper than what we would have read with just stim Ks. And if we look at the IS ratio, the asymmetry there, we have a significant asymmetry of 13.3 diopters. And if we look at the example next to that with the axis skew, you can see that this is clearly a much lower level of keratoconus, but if we look at the axis skew there, it's 40 degrees. So again, that's how we can differentiate normal from keratoconus. So if we get into the next instrument, this is going to be corneal tomography with an M. So just like the tomography that you do with retinas in OCT, what we're doing is we're taking cross-sectional imaging and we're using reconstruction to create global corneal analysis. Now you can see the slits here from a Scheimpflug camera that's able to go ahead and slice this up and give us the analysis by reconstruction. With this, we're able to get anterior, posterior, and global corneal thickness metrics derived from these imagings. Now, there are two main technologies that do this: Scheimpflug imaging, like what you see here, and OCT imaging, like what you'll see later on. So if we give a couple clicks, you're very familiar with how this works for retina, but in cornea, we use those cross sections to give you the maps that you see here. So you can see we can derive a axial sagittal map, just like the tomography curvature maps that we were seeing, or topography curvature maps that we were seeing before. But on the right of those images, you can see the elevation maps of the front and back surfaces of the cornea, as well as the global pachymetry maps, which topography cannot analyze. So when we look at the differences, Scheimpflug is going to give you a lower resolution image, but much more metrics and a wider scan image. But OCT can offer a higher resolution image that can give you individual layer analysis. And we're going to talk about epithelial mapping in a moment. So when we look at corneal tomography specifically, what we can see is on that upper right image, that is the curvature map that's derived from the tomography. So all the same metrics would apply to that curvature map on the anterior cornea as we just talked about in corneal topography. If we get to anterior and posterior elevation, these work off of best fit spheres. So if we have a normal cornea is kind of a dome shape, and if we throw a best fit sphere over the top of it, best fit sphere is essentially a dome shape as well. So in a normal cornea, the domes should match. In a keratoconic cornea, the cornea is going to be elevated and pop through the best fit sphere, giving you these islands or hot spots that you see here. In general, a good rule of thumb to look at is a anterior elevation of greater than 15 and a posterior elevation greater than 20 is likely going to be keratoconus. Now, if you see anterior elevation on its own without posterior elevation, it is likely that that is either epithelial hypertrophy or other sorts of anterior corneal issues that are not necessarily keratoconus. So the posterior is really what dictates it. And typically the posterior is going to be a more severe reflection of the anterior. Now, global pachymetry, you're looking for any point of that pachymetry less than 500 microns. These were derived from some really intense metrics and meta-analyses to come up with these values. But these are general good rules of thumb when you're looking at Scheimpflug-based corneal tomography.
And John, just to chime in here, these images are really helpful to share with patients and actually to go over. So I like to go over all of these images with my patients to let them understand their keratoconus. Now, I never ever tell them they have a duck-shaped keratoconus or cone or anything like that. But I tend to draw pictures a lot of a normal bow tie and then show them their images. But I find that actually demonstrating the corneal tomography is really helpful.
Yes, very much so. There's a lot of animations here. We're going to flip through them pretty quick, but you can see the best fit spheres here and the cornea popping through the best fit spheres that give you those islands. So what we'll get to next is corneal OCT. What you can see here is a high resolution cross section of this. And just like we're able to map the global pachymetry of the cornea on Scheimpflug, we're able to do that global pachymetry on OCT, but we can also separate out the layers. So if you give me a couple clicks, we'll get the animation here. What you can see is over the apex of the cornea, if we map out with the red line where the stroma is, and then map out where the anterior of the epithelium is, you can see that in the apex, there's thinning of the epithelium, and around the base of the apex, you have thickening of the epithelium. So in a normal individual with a normal cornea, you should have about an even sheet of 50 micron epithelium across it. Whereas in the keratoconic cornea, what you're going to see is thin spots in the epithelium corresponding with the thin spots of the overall pachymetry. And what you'll get are these epithelial donut patterns. So if we get a couple more clicks here, what you'll see is we get that sort of ring shape there. So you get the thinning in the center and the thickening around it. And clearly I like donuts, pancakes, pies, and evidently bird's nests, but maybe hash browns will be the next one. But anyway, the point being is that if we have a variation within this epithelium, specifically in this sort of pattern, this is likely to be keratoconus, and this has been associated with very early diagnosis of keratoconus. Now, the next level on this will be when we get ultra high resolution OCT, we'll be able to image the Bowman's layer on its own, and that actually has even earlier changes in it. So we'll go on to our next technology, which is wavefront aberrometry. So wavefront aberrometry is a way to objectively measure the visual quality of an individual. And I find that this happens to be the most helpful when I'm talking with the patient and letting them know that I understand what their vision is like and what they are going through. So the way that this technology works is we project light into the eye and we watch the reflected light coming back out of the eye. That reflected light hits a micro lenslet array. So you can imagine a micro lenslet array being almost like the eyes of an insect, where you see those multiple little lenses, right? What you're getting is that light hits that and it focuses to individual points on a sensor. And these are the sensor images that you'll see. On the left, you're seeing the normal cornea. And what you're seeing is nice even spacing of those focal points. And you can see that they're very planal, they're very even, indicating that they have very equal refractive surfaces, or excuse me, refraction of light across the cornea, or rather, not the cornea, across the entire ocular structure. The wavefront aberrometry is looking at an analysis of the eye as an entire optical system. So this instrument alone will not be able to diagnose keratoconus definitively, but it can give you a very good idea that keratoconus might be present, because certain patterns and aberrations are associated very highly with keratoconus. So on the right-hand image, what you're seeing is the keratoconic cornea, and you can see that the focal points are much more deviated. You can see that there's a big difference between the defocuses of those points across the sensor. Now you can take that image, give me a couple clicks here. What you'll see is you can show them a point spread function, or you can map it out to show the deviations there, or you can go ahead and turn this into bar graphs for individuals to show them the individual polynomials or aberrations that are degrading their quality of vision. So when we look at this, probably the easiest way to understand this is a point spread function. So what's a point spread function? Single point of white light on a perfectly black background. If you had a perfect optical system, you would see, and this is something that we can all test at home right now, if you're looking at this dot and you see a perfect dot on a black background, good for you, you have great corneal optics. When we have deviations of that light and we're starting to have spreading of that light, that's where we can start to understand the type of optics that our visual system has. So if we get another click here, we'll go ahead and we'll show the different types of aberrations that are present. If we look at defocus, defocus is myopia and hyperopia. Astigmatism is obviously astigmatism, and those are corrected with the typical spherical and cylindrical lenses that we have. But then there are higher order aberrations: spherical aberration, coma, and trefoil. This is what we're going to get with as halos, flare, and starbursts, right? Flare being the coma, kind of that streaking or comet tail-like effect, trefoil giving you that starburst effect, and spherical aberration giving you that halo effect. Those are what we refer to as higher order aberrations. The ones that we can correct with glasses, defocus and astigmatism, are what we refer to as low order aberrations, and those can be corrected. I believe I just said that with glasses or traditional soft contact lenses. So Yeah, I guess we can sort these in orders. Again, that's where we get the term higher or lower order, and this is what we would call a Zernike polynomial table, where we can separate out the various different patterns of aberration that's created by these optical systems. So we covered that. Sorry, I ran through that pretty quick. So yes,
I think
you can
that's
lower order aberrations getting covered, higher order aberrations being what's associated highly with keratoconus, specifically trefoil and coma. Now, aberrations are variable. This is why individuals will tell you that their quality of vision goes down at nighttime. The larger their pupil, the more higher order aberrations we're getting through that, but it's also an age dependent thing. So this is kind of a three factor that are contributing to the aberrations present. This is Marsak's seminal work on this, working with Ray Applegate out of University of Houston, but this is tremendous work in the understanding of not just keratoconus optics, but optics in general in the eye. So as we move forward, what we'll see is that wavefront aberrometry alone is just looking at the whole eye optical system, and it's impossible to say for sure that you have keratoconus unless you combined your wavefront aberrometer with topography or tomography. So if we get another click, I think maybe 2 clicks here, what you get is with a topographer, you can separate out what's coming from the anterior corneal shape from the whole aberration. So other sources of aberrations can be things like, irregularity in the crystalline lens, or even irregularities in the vitreous can contribute to that. And obviously the posterior cornea. So if you look at the eye as essentially a lens system, the cornea is one part of that. And if we know the shape of the cornea, the anterior cornea, we can eliminate what's happening behind that as a factor. So if the vast majority of the aberration is coming from the anterior cornea, we know that it's likely those aberrations are coming from that point source. Now, there's posterior cornea that's not being attributed to if it's a topography plus aberrometry system. What we really need to eliminate the cornea altogether as a factor is the use of tomography. So tomography, if we get one more click, we'll get the anterior and posterior cornea and look at total corneal aberrations and be able to subtract that away from the optical aberrations of the entire ocular system and definitively say, okay, that cornea is a keratoconic cornea, and the aberrations are coming from that. So if we look at like Lee and Kosaki's work on this, what they were showing was that higher order aberrations in general are elevated in keratoconus, but specifically vertical coma is the predominant aberration that is seen. So if you see a good amount of aberrations, you really want to get your corneal topography to rule that out, and you have a higher likelihood based on the specificity and sensitivity of vertical coma that it is in fact keratoconus. I think there's probably a lot of animations on this one. Oh, thank God I took those out. Okay. Continue.
Excellent job there. So now moving on to genetic testing. So we do have a genetic testing, which is really helpful when we're looking at our patients, not only for keratoconus and corneal ectasia, but also for corneal dystrophies. And we can use this in our practices either for keratoconus management, those who are maybe interested in refractive surgery, and there might be a little bit of a questionable part, like, are they a good candidate or are they not? And so this helps supplement the additional data. So it's not just a one and done. We don't just do a genetic test and say, here's your risk score, there you go. We do need to do an eye exam. We do need to look at the history, environmental factors, other systemic factors when we're talking about keratoconus. And this will help us confidently make decisions. So for example, sending a patient for cross-linking sooner. For example, monitoring a patient a little bit sooner than you might have before. And of course, family history is very important here too. So we talked about all the measurements that we're going to take. We can do corneal topography, tomography, wavefront, global pachymetry, doing the eye exam. We do want to manage any environmental allergies, atopy. We don't want our patients to rub their eyes, and actually writing that down, get in written instructions, I think is very helpful, like please avoid eye rubbing, and giving them different tools. And Avogen is the genetic test that we can use and here I'm going to talk a lot about keratoconus. So there are 75 keratoconus related genes. And here you can see that there's a polygenic and there's a monogenic test. The monogenic is for corneal dystrophy. The polygenic is the keratoconus risk. And there are other additional tests that are coming soon as well, but tonight we're going to focus on Avogen specifically for keratoconus. So here you can see the risk assessment, and this is really helpful. So it gives a number, it gives a score. And as you can see on the right-hand side, it also lists all the genes that are associated with keratoconus, which is quite helpful. It's important to know that this information is checking specifically for these conditions. It is not a genetic test that is going to test for all other conditions. This information also is not going to be shared. And there are genetic counselors for yourself and for your patients if you'd like to go over this information, which is quite helpful because I'm not a geneticist, but it's nice to know that I do have someone who can talk to my patient about all the genes related to keratoconus with them. And again, this is not just for keratoconus, it's also for corneal dystrophy. It's very interesting, I think, if you're testing different family members, if you're testing siblings, if you're checking a parent and a child, to actually look at the genes and see the ones that are the same, the ones that are different, because keratoconus definitely has a genetic component. So you might say, well, when do I do this? When do I actually think of running this test? And if there's a family history, that's just an ideal time. The nice thing about the Avogen test, it's a cheek swab. It can be done in babies and children. It can be done in really young patients. It's very easy to do. We talked about all the different red flags in younger patients, increase in myopia, increase in astigmatism. We talked about the axis of astigmatism. Those whose refractive error is changing, or you're doing a refraction, or this often comes up, which is so true, if you have some sort of automated refraction and then you actually perform a refraction and the numbers just don't add up a lot, that's also a good reason to be concerned. And then when we're looking at refractive surgery, so those prior to refractive surgery that might be a suspect for keratoconus, have a family history, have other conditions associated with keratoconus, or an increase in astigmatism, and it's a helpful tool that can be used there as well. So since keratoconus has a genetic component, it is very helpful to have this information as one tool in our toolbox when we're managing our patients with keratoconus. There are many studies that are looking at all the genes that are associated with keratoconus, and I think that you'll see one coming up here of all that. Here we go. You don't have to memorize this slide at all, but I do want you to appreciate just how many genes are associated with keratoconus. And this is really new information. Even in the past few years, there have been more genes associated with keratoconus. So there is actually conclusive evidence that there are many genes associated with keratoconus, and I think that there will be more also with time. And so it's nice to have this option to be able to check our patients who are a suspect for keratoconus or corneal dystrophy. So I think we talked about all the findings, and I am purposely running through this quickly because we have a lot to cover. But those who you've checked a corneal topography or tomography, John sort of mentioned earlier, but really important, those for myopia management. If you're thinking of doing a corneal-based procedure like ortho-K or a corneal refractive surgery, we might, and you're kind of thinking, well, is it just myopia or is it more than that? Could it be keratoconus? Then that would be an ideal time to actually run the Avogen test and check for keratoconus. And of course, if there's a family history. So you might say, well, how do you actually do this test? So it's a cheek swab. So you have a vial, you actually have a sterile swab, and you just swirl around on the inside of the cheek for 20 to 30 seconds, and you put it in the little vial and you repeat it 4 times. So it's actually quite easy to do. You can do it in the office, your patients can do it themselves. There's also a video explaining how to do this. If your patient wants to watch the video, it's very, very straightforward here.
So we're going to blow through some corneal biomechanics. This is kind of a holy grail area, and currently the biomechanical devices that we have available in the US are not sufficient enough to be able to differentiate early keratoconus or subclinical keratoconus from a normal cornea. But in general, if we look at corneal hysteresis or corneal resistance factor, essentially what we're looking at is the deformation of a cornea under a wave, under an air puff. And instead of doing the video of it, like what we had seen with the Scheimpflug version, they're just using a simple IR projector and sensor. And as we deform, the curve is created. So once we hit our applanation point, we hit our peak. As the cornea continues to deform in, we have a loss of that peak. And then as the cornea rebounds back up, we have a second peak. And then we have our pattern of corneal biomechanics. If we see a reduction in those peaks, especially a asymmetric reduction from the first applanation point to the second applanation point, that could be an indication of keratoconus. And they've shown that severe keratoconus versus, moderate keratoconus compared to normal corneas can be markedly easy to find on this. So let's go ahead and keep moving forward on this. We talked about Scheimpflug deformation. The big factor to know on this is the AT1 value, which is how fast the cornea deforms with the initial puff, is highly statistically significant with keratoconus. We'll go to the next one. We talked a little bit about, this one's kind of cool. Essentially, this is where multifactorial diagnoses come in with AI analysis. We can take our corneal structural map with our tomography and then combine it with the biomechanics, and then we have a risk profile that's created by looking at the corneal biomechanics plus the corneal shape. So in individuals who we may have said, hey, you have a totally normal corneal shape, but they have abnormal corneal biomechanics, those individuals may be at more risk of keratoconus. And if we go to the next one here, what we'll see is the two biomechanical methods that we talked about at the beginning of the presentation. These are really in laboratory settings only. However, Brion spectroscopy is being looked at in Europe and maybe in the market within the next couple of years. OCT elastography, on the other hand, may take a little bit longer, but they are doing something called PhD OCT, which is essentially looking at phase shifts within the cornea to associate that with strength profiles. So I think we can wrap up biomechanics. But basically the idea here is that we're going to take a combined data approach. Think like how we do glaucoma, right? We look at multiple diagnostic factors, we bring them all together for the earliest diagnosis. And another similarity between the two is that both are progressive diseases. And even if we do interventions, whether it's MIGS or corneal collagen cross-linking, we still need to monitor those individuals after those interventions to make sure that they're not continuously progressing. Now, one of the things that we like to talk about is multifactorial devices. If you have something that's a topographer plus an autorefractor, using the full functionality at the same time can be very helpful in finding these patients. And if you're going to run on that device anyway, just simply running the topography at the same time is ideal. Perfect. So when we come to our monitor management of keratoconus, it's really 3 points. of the actual management strategy, which is stopping progression, improving topography, and improving vision. So the first step on this is stopping progression. So that is cross-linking. Now, the history of cross-linking, this was done at University of Dresden. What they really looked at were multiple candidates to try and strengthen corneas. What they found that was most statistically significant was the combination of riboflavin and UV light. And the photochemical reaction that occurs within the corneal stroma creates these oxygen radicals that causes more strengthening, or rather these crosslinks to form within the proteoglycan matrix of the collagen structures to be able to create the stiffening effects. So this was providing the most highly statistically significant stiffening out of all the various different agents that they tried. They tried things like glutaraldehyde and Konosky's solution. These are typical hardening agents or preservative agents. So if we get to in vivo cross-linking, this was the first study that was really the seminal paper on this, and this is using a technique that the US FDA approved cross-linking technique is based on. Essentially, this was a prospective trial. They looked at preoperative progressing keratoconus, and postoperatively after the procedure, they found that the cornea is actually flattened a bit. And what you're seeing here is the differences between the K max values. You can see before the procedure, they were progressing at a rate of, or excuse me, not before the procedure, but in the control group, you can see that those individuals were progressing by 1.4 diopters, whereas the individuals in the treatment group actually had a regression of 2 diopters.
So when FDA approved cross-linking, when it was approved in 2016, that was really exciting, and it still is quite exciting because many patients were going outside of the US to have cross-linking done. But at that time, and even a few years ago in California at least, we were having a lot of trouble getting cross-linking covered. But fortunately, the coverage is much, much better now. And as you can see, it's covered about 95, 96%. And there are different ways of showing progression. And it really depends on the patient's insurance and what is needed. So really carefully documenting, monitoring, notating exactly where your patient is, repeating measurements, because it depends on what the coverage is to how you have to document that progression. But I'd say taking very careful note taking is really helpful in order to document progression. And here you can see the economic benefit of FDA approved cross-linking, which is maximized with early intervention. Earlier in the lecture, we talked about the economic impact of keratoconus and on a patient's quality of life as well. So here you can look and you can see the cost savings with cross-linking over a person's lifetime. So very helpful. So John, who gets cross-linked in your clinic?
Yeah, so really what we look at for cross-linking is documented progression of the disease. Obviously, we'll get you cross-linking, but also in the pediatric population, we don't wait to prove progression on this. In the literature, it has been repeatedly suggested not to wait. These individuals we know are at higher risk for more advanced diseases. So these individuals, upon diagnosis, we'll have them cross-linked. But yes, documented progression, pediatric patients.
And what about pregnant patients or patients who are going to get pregnant?
I would say, yeah, for individuals who are family planning, definitely cross-linking for them. When we look at documenting the metrics here, there's a variety of different things that can be used, and the criteria changes from insurance company to insurance company to qualify an individual as progression. In some individuals, that's as little as a change in axis of 10 degrees. So it seems somewhat arbitrary because we know in keratoconic individuals, we could do 2 refractions back to back and get a variation of 10 degrees. So, but that's good for your patients. But that being said, we want to just document, just be very, very diligent about tracking these sort of metrics that you could follow in your practice. So this is actually a very important slide on this. Was COVID, as bad as it is, it did have some interesting opportunities that came out of it to really look at how delays in care can affect our keratoconic population. This was taken from, I believe, Moorfields. And what they found was that the individuals who were on pause for cross-linking for a 3-month period of time while the UK was kind of in their lockdown, these individuals were not having cross-linking performed. And what they found was that there was a 70% of these individuals who had progressive keratoconus progressed significantly during that period of time of just 3 months. So it's extremely important to get these individuals into to get their cross-linking and express the importance of having this procedure done in a timely manner so that they understand this is not something to wait for.
And what I take away from this study also is just the importance of monitoring. So say you want to see your patient back in 4 months, stressing why you want to see them back in 4 months, even if you're not planning on cross-linking, but you're monitoring for progression so that it's not a year or 18 months or 3 years later, and then they've progressed so far.
Exactly. Now, the question that's come up is, in pediatric keratoconus, how often do individuals progress afterwards? On average, it's about 10% progress after corneal collagen cross-linking. There is some variability in this, and that comes from because these are mostly international studies, and these international studies use a variety of different techniques. So, but on average, what they see in the systematic review is that it's about 10%, and that kind of gels with the overall rates of progression after cross-linking. Now, the good thing to know is that cross-linking can be repeated if progression is continuing. So before you do cross-linking, you're going to establish your baseline measurements.
John, do you check uncorrected visual acuity?
Yeah,
So
I mean,
on that list there.
Yeah, it's one of the things that it's just good to have, that just be comprehensive in these things. You never know. And some of the criteria, uncorrected visual acuity is one of the things that, we follow. And when we saw the clinical trial, we actually saw an improvement, only by a line, but a line was statistically significant in the clinical trial.
And it is important to check a refraction. So even sometimes our patients are coming in for specialty contact lenses. It's important to check a refraction without the contact lenses on, and then also checking their best corrected vision with whatever method that is and showing the comparison between the two.
Yes. Now, the big one on this is setting expectations for the patients. Let them know that this is not to improve your vision. The purpose of this is to prevent further loss of the vision. Many individuals, when we were first doing this, were very upset afterwards, going, my vision isn't any better. That is not the purpose of it. The vision will initially be a little bit reduced, and it will start to improve after the 1 month mark. Generally 1 month to 3 month, we have a little reduction because of some corneal haze that is created because of the procedure. That is not scarring, not DLK, none of that. There's just microarchitectural changes within the corneal stroma and the anterior cornea. And it does return to baseline afterwards, or near baseline. Now, express to them that they need to be continuously monitored, and contact lens wear can generally be resumed at about the 1 month mark.
And sometimes even less than 1 month, depending on the case.
Exactly. Basically, once the epithelium is smooth, go for it. Basically, the procedure is to remove the epithelium. This is apply the riboflavin drops for 30 minutes, check that the cornea is fully saturated, then illuminate with the UV light for 30 minutes, continue your drops throughout that period of time, and then go ahead and put your bandage contact lens in after you've kind of rinsed things off, given a little antibiotic and a little steroid, and then you're good to go. Post-op period on this is essentially Just like PRK in the early phases, you just want to see that things are looking normal and things are healing. Day 5, you can remove the bandaged contact lens and just make sure that there's no epithelial defects. Drugs are exactly the same as what you would do during PRK. Long term, you're really looking for stability and monitoring those metrics that you took for baseline. So the phase 3 clinical trial data, essentially what we're seeing in this is that the individuals who were treated flattened by about 1.6 diopters, and the individuals in the control group who were not treated progressed 1 diopter. Now, there was another arm that looked at corneal ectasia, and it's important to do cross-linking in your ectasia patients. We also found that these individuals were a lot more variable on their retreatment rates and the ability to keep them stable, but these individuals can progress at any time. And it's very sporadic and random. So it is also effective in corneal ectasia. So we looked at the 10-year data in our clinic. We did a retrospective review on this, and what we found was over a 10-year period of time, about 93% of individuals with keratoconus were stable overall. You can see that those numbers are less than the ectasia group. Again, we can see that ectasia may be a little bit of a different beast, and thus we're doing some genetic studies in our clinic as well to see what the difference is in ectasia profiles. So cross-linking works. Effects with contact lenses, there's a minor corneal curvature change, so this is not something that you really need to be concerned with. We know that the cornea is going to flatten a little bit, so generally this is not something that you fully need to refit individuals for. As far as refraction is concerned, you may have a small amount of refractive change, which may require a power update, but generally the shape of the lens is not going to be hugely affected in that area. And it's definitely not going to be affected negatively. It's not like the cornea is getting steeper and you're going to have more apical rubbing. We know that it's flattening, so you may have a little bit more apical clearance. And that's just an overlay between a pre and a post-op cornea, and you can see that the two corneas are just perfectly overlapped on each other. There's virtually no appreciable change for a contact lens fit. Why do we limit our talk to the epi-off procedure? It's because that's what's approved in the United States. Globally, there's a ton of different innovations, changes to riboflavin, the way that the riboflavin is delivered, the UV light, the power, the time, the tracking, pulsation, the ability to saturate the eye and give us more supplemental oxygen, and even the indications. We can use it in some cases for corneal refractive, but also for treatment of microbial keratitis, because of the energy that's created can burn up bacteria and viruses. So future of cross-linking in the US, there are 2 different versions that are going on. This is the one that had top-line data presented. The publication was just released. Essentially what we're looking at here is the use of oxygen saturation goggles, these boost goggles, and a transepithelial approach. Now this has been submitted to the FDA, but that does not mean that it is approved by the FDA. So do not wait around for this to be approved to give your patients an option for cross-linking. Use what's available right now. This may be a good option in the future, but it is something that's going on. You should be aware of that. The other one is a laser diode treatment. This is currently in the early stages of phase 2. We're doing this at our clinic along with, I think, 3 other sites. It is very, very early days on this, but it is a very cool variation on this. Instead of doing a broad beam of light, you're doing little micro pulsations with laser diodes, and it is to keep the oxygen regeneration higher. So very, very cool technology. So innovations are coming. So the next one on this is the modern management to improve topography. If you can make a more round cornea or a more symmetric cornea, you can have better optics.
So, John, a common question that often comes up about cross-linking is what to do first, cross-linking or a specialty contact lens. And so I would definitely recommend to have, especially in a child who you know is progressing and they might be progressing pretty rapidly, to have an in-depth conversation about cross-linking. And that could be, can sometimes be an hour-long conversation with the patient and their parents, but it's really important to go over all of the metrics and all the findings, and if possible, have them cross-linked first to stabilize that cornea prior to the specialty lens fitting. Now, as we mentioned, it is fine to put a contact lens on even 2 to 4 weeks after cross-linking, but I'd encourage you to get the patient in the right place to stabilize the cornea first.
Yeah, and what we do in our center as well is definitely cross-linking first. Always the disease comes first before the lens. But sometimes what we'll do is we'll do this concurrently. So I'll start a contact lens fit, and that week, right after I've done the fitting, they'll go and they'll have their cross-linking. Lens is going to take a week or two to get in anyway while they're healing. Then we go ahead after they've healed, we do our INR. They wear it for a week. We're already at that 3 to 4 week mark. We continue the process from there. And that way we can kind of get everything done in a more expedited fashion.
Very efficient. Sometimes we'll do the insertion and removal prior to cross-linking just so that they feel comfortable with it. Okay, moving on to improving topography.
Yes. So why would we do topography altering procedures? Well, if we can get better optics out of the cornea by making it more symmetric, we can improve the visual acuity in glasses. One of the big ones is balancing anisometropia between the two eyes. The other thing that we can do is actually benefit our contact lens fitting. I know that Intacs have a pretty bad rep on this because it was touted as being able to do that. But topography guided PRK and other procedures are definitely doing that. So we'll talk about that. And obviously, if we can make the cornea more round, we can actually improve the accuracy of cataract surgery and give these individuals much better results afterwards. It is notoriously difficult to hit a refractive target in an individual with keratoconus. So if the way that we would do this is we can either remove a little bit of tissue, we can add things to the cornea with implants, or we can replace the tissue with keratoplasty. Now, why can we do removal techniques? It's because of cross-linking. We've now strengthened the cornea. We can remove just a little bit of tissue and not destabilize the cornea. It's been shown long-term that that actually has been stable with the Athens protocol and the 10-year data on that. So let's get into topography guided PRK. The way that this works is essentially we take our topography and that data gets submitted into the laser, and we create a custom profile to affect the cornea to create a more symmetric shape. Now in the US, we have topography guided LASIK that was FDA approved in 2016. This is a little different variation on the technique. Instead of doing LASIK, we're doing PRK and we're using it topography guided. But this can be used to effectively smooth out a cornea a little bit. Now, if we go to the next slide, what you'll see is the difference between a myopic profile, and what you're seeing in a myopic profile is that we're doing a global removal of tissue. Whereas in a topography guided profile, what we're doing is we're just nipping the areas that are a little bit irregular, a little elevated, so that we can create a more smooth optical profile. These are actually profiles both for a -2 on a regular cornea, and you can see we have these little micro elevations in even a normal cornea, and if we can smooth those out, we can give them even better vision like what we saw in topography guided LASIK, but we can do this in topography guided PRK for keratoconus too. So let's go ahead and move to the next one. What you're seeing here is actually the way that we would do this procedure. This is the type of ablation that you see. You can see that we're more focal over the apex of the cornea, and we get a little arc up top. The idea here is to normalize the corneal shape by bringing down the apex and steepening the superior cornea or the flatter cornea. So if we give a click, what we would do is we would then hit it with some the photon rays here, and that would remove the corneal tissue in the focal pattern. and then we would end up with this sort of epithelial defect. So you can go ahead and give one more click, and you can see how this matches up with the shape of the ablation pattern that we were showing before. And you can see the results at the bottom. That central image is the pre-op, the image off to the left is the post-op, and the image to the right is the difference map. Now, this is a tissue sparing technique. We are not removing a ton of tissue to create like a 4 diopter or an 8 diopter change. We're removing very, very sparing amounts of tissue in certain areas in very small zones to create effective curvature changes without destabilizing the cornea. So what are the effects here? We flatten quite a bit. This will have very little effect on your scleral lens fitting, but it will have significant effect on any contact lens that will rest on the cornea. So after topography guided PRK, GPs, hybrids, soft lenses, all of those would need to be refit. Scleral lenses, not necessarily. You might need to change the power, but it's not going to, because you're only removing like 40 microns, it's unlikely that you're going to change things there. So again, this is kind of the differentiation. If we overlay the anterior and the posterior of the cornea over it, you can see that we bring down the apex with the red line, and we bring up the periphery in the flatter portion of the cornea. Intacts I'll rip through because these are, we know what they are. They're polymethyl methacrylate arc segments that we implant into the cornea. They are placed about an 80% depth in the cornea. These were originally approved for the treatment of myopia and were approved for under humanitarian device exemption in 2004 for the use in keratoconus. So when we do this, this is a space occupying implant. What it does is it causes focal flattening inside of the segment by raising the mid periphery of the cornea. So we get a couple clicks here. What you'll see is that's the effect. We lift that peripheral cornea, and what happens is in that area of the peripheral cornea where it's being lifted, again, like we have an apex in a cornea where there's remodeling over the top of the keratoconic cornea, we get remodeling over the portion of the segment, so the epithelium actually thins out. So if we get one more click, what we'll see is in contact lenses, or one more click, we'll get to contact lenses. If we're using a corneal gas permeable lens and it lands at the optic zone where the intact is, what we get is friction over that thin epithelium and thus breakdown of the epithelium in that area, which is why we have complications related to intacts and corneal gas permeable wear. These complications are actually entirely solved if you use a soft lens or a scleral lens to vault the area, or even a hybrid lens that's slightly decentered to vault the area. But basically what would happen is if we cause force to it, we end up with rubbing, breakdown of that epithelium because of the plastic sandwich, if you will, of that tissue there. And over time, that can lead to inflammation, neovascularization, sometimes even stromal melt and extrusion of the segment. So you can see the breakdown of that tissue. We want to avoid that. Now in our clinic, we looked at complications of intacts that were implanted, and we found that there was about 6% of the intacts that we implanted would need to be removed either for medical or refractive reasons. Now, why is this happening? Some of this is due to biocompatibility issues and having synthetic material in the cornea. And you can have melts or neovascularization and inflammation present, like what you see in the images here. Sorry, I have a lot of animations in these, sorry. So the CTAC procedure is a procedure that we've innovated in the US. We've been working on this since 2006. Essentially what this is using fresh or preserved corneal tissue, shaping that on a femtosecond laser and then implanting it into the cornea. And we can do totally customizable shapes, but we know that the biocompatibility of corneal stroma within corneal stroma is very, very good. So if we go ahead and we move forward with this, especially because this is preserved tissue, meaning that it's gamma irradiated and we eliminate all the antigens in it, there's nothing for it to react to within the innate immune system. So you can see how this tissue heals over time. You can see on the right, the image, it's almost entirely invisible. If you give one more click, you'll see the retroillumination on this, or rather the, good God, the fiber optic effect of the cornea. I'm totally forgetting the name of this illumination. Anyway, what you can see is just the very, very faint outline of that implant within the cornea. And we can do dramatic changes to these cornea. If you're fitting contact lenses, virtually any of them, they're going to need to undergo refitting afterwards, even in scleral lenses. And you can see the big elevation changes created here in the peripheral cornea. Now they're fully customizable, so we can create huge changes. You can see in the severe cornea, we're able to flatten this individual 36 diopters, but we can modify it, and even in a mild individual, we're able to change it only 5 diopters. So it's a fully customizable treatment for individuals. And these are just comparing the keratoconus surgeries and what they can do for uncorrected visual acuity, as well as best corrected visual acuity, and average K value changes with those. Keratoplasty, we know, can be very effective.
So one thing to add in about keratoplasty here is the importance of actually checking vision with the best corrected vision with some sort of specialty contact lens. So whether that's a corneal lens, a scleral lens, whatever it is, because I've had many patients who they're 20/20 with their scleral lens, they're happy, they can wear it all day long. They go to an outside location and told that they need a penetrating keratoplasty. So then patients call me and say, do I really need this? And I asked, well, did you wear your lenses to the appointment? Did you tell them that your vision's fine? No, didn't do that. So very important, but I think we have some studies coming up here as well. So here you can see a full thickness penetrating keratoplasty. Whenever a suture is removed, it can definitely change the amount of astigmatism and irregular astigmatism on that corneal surface. And so, which can definitely affect the contact lens fit. But here you can see the keratoplasty PK versus the DOLC. John, in your clinic, how often are keratoplasties being performed compared to, say, 10 years ago?
Oh, rare. I would say, and we even see this in the overall eye banking data, that the decrease in penetrating keratoplasty has been dramatic. Even in anterior lamellar keratoplasty, it has been a big decrease. Yeah, are you seeing the same thing at Davis?
Yep, and I think we have some studies, the studies coming right up in just a little bit as well.
You can use a femtosecond laser to create intricate cutting and very, very intricate keratoplasties with this. The idea being that you're going to increase the surface area of the graft-host junction and make them more stable.
The risk of graft rejection is very significant. We do want to document, so if there's any vascularization, as you can see here on the upper right, if there's a history of rejection or graft reaction, if there is herpetic disease or any sort of ocular surface disease, which many of these patients have, there's a higher risk. A lower risk is those who do not have any corneal neovascularization, but endothelial rejection is oftentimes most common, and many of our patients are on steroid drops very long term. Now, there's always a risk of rejection or reaction of that graft, so we want to counsel our patients that if their eyes getting red, if their vision changes, if they're having any problems at all, really to come in sooner rather than later so we can get it under control to prevent another corneal transplant. And here you can see, I like this one, if there's any redness, photophobia, pain, or decreased acuity, to come in right away. And some of our patients are not really looking at themselves in a mirror, so having someone else look at them to see if there's any redness of their eyes, and that's been very effective to actually educate our patients to prevent the need for additional corneal transplants. And here you can see endothelial cells and how they change the endothelial cell density over time. And it definitely decreases over time, but especially in our patients who have corneal transplants. And they're much more at risk than, say, someone who has keratoconus and has cross-linking, which is why it's so important to cross-link, stabilize the cornea to prevent a corneal transplant.
Yeah, so we
Which
look
gets
at
to our
that.
next point.
Yeah, exactly. If you look at the PK utilization after the initiation of cross-linking as a standard of care in Utrecht, what they found in the Netherlands was that they found initially a 25% decrease. These numbers have actually grown over time, so we see even less of these being performed. And if we go to the eye bank data here, if we compare in the US, pre-FDA approval to even 3 years post FDA approval, we can see that corneal ectasia is now the second most common indication, a 56% reduction in the corneas used. And the number one reason for transplantation is now repeat corneal transplant. So it's a significant change. So modern management then ends in improving vision. So I think we can probably get through this in 5 minutes here. So visual rehabilitation of these individuals is extremely important. We can do it with glasses, specialty contact lenses, and even IOL and ICL in the right candidates. So contact lenses for keratoconus, there are a variety of them, from soft to corneal gas perms, hybrids, scleral lenses. All are very good options for individuals. If we look at this, the big thing to kind of hit on is the goal of this is to improve their vision, maintain good comfort, but overall and most importantly, maintain the ocular health and make sure that the cornea is not progressing. It is extraordinarily important to reinforce the truth that that contact lenses do not slow or stop progression of keratoconus. Now you can use some of the technology to understand the corneal profiles, which may help you choose or select a lens for an individual with keratoconus. Standard
Yeah.
soft lenses can be used. Common issue
In
here.
mild keratoconus, or those who have very maybe normal or a little amount of astigmatism, not huge amounts of astigmatism, but there can be a lot of problems with standard soft lenses. There can be fluting, as you can see here, excessive movement, poor comfort, and again, it's really important that we maintain ocular physiology. So here are some parameter ranges. But I would say just kind of moving on to a custom soft would be a much better option. Corneal GPs are a very helpful tool in both of our practices. I always like to say that because sometimes I forget, but corneal GPs are a wonderful option. So they give really good vision, they have great tear exchange, cost effective, and less complex than other designs. So if you're not fitting a lot of corneal GPs, pull them out, start fitting them. When we're fitting, we want to start centrally, assess peripherally, depends on the type of keratoconus. If we want to go to a smaller lens, a larger lens, sometimes simply changing the diameter and the design, especially in the post-BK patients, can be really, really helpful, and they're just a great tool. This is the CLICK study, as we had mentioned previously. This is looking at scarring in patients with keratoconus and showed that corneal staining, there was a higher risk of corneal scarring. So we want to make sure that we are not bearing on that cornea and touching on the cornea. This was interesting looking at keratoconus and disease severity. There was no association with the central fitting relationship. And when we're fitting our patients, we just want to make sure that the lenses are centered, they're moving well, that they're comfortable. We can add surface coatings, which I find are really helpful for corneal GPs in general, including those with keratoconus, many of who have dry eye as well.
Perfect. Yeah, and we want to avoid lens bearing issues. Obviously, this is what's going to cause epithelial breakdown and corneal scarring. And just a image of ideal pressure distribution versus unacceptable apical bearing, and a difference between scarring caused by keratoconus as a disease. You can see the nebulous-like scarring that's all the way through the cornea. That's more what you're going to see that's caused by the disease. If you're seeing apical anterior scarring, that is caused by the lens, and that needs to be refit. Custom soft lenses can be a great option for these individuals. Wonderful for people with GP intolerance, great for mild and moderate cases. And it's a very simple transition for individuals because if they're used to wearing soft lenses, they pretty much maintain that with this.
And there are many different types of custom soft lenses out there for keratoconus. You don't have to have all of them. I would encourage you to have one or two in your practice. It's a really helpful tool for patients, and surprisingly quite good vision out of the custom soft option as well.
Perfect. And you can just see the differences between the thickness profiles that you can get on these lenses. The reason why these lenses are able to mask some of the irregularity is the thickness gives it a pseudo rigidity, which can give you a new contour to the cornea and thus give you improved optics. And this is just a difference between the Meyers of an eye without the custom soft lens on versus the custom soft lens on, and you can see the roundness of the Meyers with the lens. Hybrids are an option as well. One of the biggest misnomers in this, though, is that hybrids are going to provide vision of a gas perm and comfort of a soft lens. That is not the case. They should be best described as a gas permeable lens, the optics of a gas permeable lens, and improved comfort over a gas permeable lens, and with better centration.
And they provide really good optics because of the gas permeable lens and their high decay materials for the soft skirt. And here you can see some images which can be used in normal corneas and irregular corneas, including those with keratoconus. And empirical fitting can be done. So taking the information directly from the technology, the topography can be done to fit hybrid lenses. Piggyback lenses, I would say, are still a really helpful option in our practice because some patients, they have the really good vision with the corneal GP lens, and the soft lens can either stabilize the corneal GP and or make it more comfortable. And so there are different ways of doing this using a daily replacement soft lens. Sometimes handling can be an issue with that soft lens, and then fitting the corneal GP over. You can also use this if there's, say, a corneal abrasion. And here you can see a piggyback lens system with an excavation design centrally with the GP there, and then the soft lens. Scleral lenses, definitely a great option for patients with keratoconus. You can see some beautiful images here. We do have the Scleral Lens Education Initiative that you can refer to for all things scleral lenses. Scleral lenses have shown to be very safe for patients, even those with keratoconus. Here you can see Dan Fuller's study. And there are many different scleral designs, again, many different resources for scleral lenses that we're just going to touch on tonight. But here you can see a patient with severe keratoconus and the beautiful images there with the scleral lens. So you want to make sure that the scleral lens vaults the cornea, lands on the scleral conjunctiva, does not touch the cornea. There are many great designs, materials. We want to make sure that there are not any bubbles under the lens. And you could see from the kind of earlier picture that how beautiful that scleral lens landed. We have advanced technologies now to fit lenses. We have advanced diagnostic lenses. We have impression-based scleral lenses. So I'd say it's still a very exciting time in scleral lens fitting. Of course, we can use our technologies to improve scleral lens fitting. Here you can see with anterior segment OCT. And we can make notches and different elevations within the lens. We can fenestrate the lenses, make channels within the lenses, and have very specific designs to better align on that scleral conjunctiva even than we did years ago. Looking at the scope study here, 74% fit for corneal irregularity, primarily keratoconus. In the Scleral Lens Initiative, 77% fit for corneal irregularity. And now scleral lenses are still growing and more practitioners are fitting them. And so going back to the early diagnosis, the importance of diagnosing keratoconus early, actually stabilizing that cornea, fitting them with any sort of specialty contact lens is really going to help our patients long term.
Lenses in advanced disease, what they find is if you're comparing outcomes with intracorneal ring segments or lamellar keratoplasty compared against a scleral lens, the scleral lens hands down has the best outcome. The impact on corneal transplants, Coppin's work on this, she's an ophthalmologist in Antwerp. 51 of the eyes that were referred to her for corneal transplant, of those 51, 40 of those could be successfully fit with a scleral lens and avoid the need for a corneal transplant. Krebs showed similar information about outcomes after high drops and the success with scleral lenses for those. So,
and then Jenny Ling also did a study there showing the same thing. So, and these are patients with severe keratoconus.
Yes. Now, higher order aberration correction is something that we're going to touch on very, very briefly. Scleral lenses, and you can just kind of rattle through these slides. That way they can see the images, but I'm just going to talk. Scleral lenses and any type of lens over the top of a cornea is not going to fully correct the optics. You're going to have residual aberrations, which are the results of not just the posterior cornea, but also decentration of the lens. Now we can do higher order aberration correction in these individuals by using a wavefront aberrometer to capture the aberrations of the eye plus the lens optical system. We can take that aberration data, mirror it, manufacture it into the front surface of the lens, and just like noise canceling headphones, we can cancel out some of those residual aberrations and improve the quality of vision. Now, this has been shown in a multitude of different studies over the years, showing anywhere from about a 40 to a 65% improvement in the aberrations and a 1 to 2 line visual acuity gain for these individuals. So once we get to clinical practice these days, there now is a opportunity to use a integrated system that exists in our clinical practices. That's able to do the whole thing. We have a lens that has a dot matrix for marking where the lens orientation is. The system will then find the differences between that and know exactly where to place those aberration corrections. What we found in our retrospective review of this is a increase in visual acuity of about 1.5 lines and a 55% reduction in aberrations of those individuals. And you can see the difference between traditional optics in an individual with keratoconus versus the wavefront guided scleral lens optics. So this is a tremendous opportunity for your scleral lens patients. Sorry, there's like a whole bunch of animations on this, and then the study data. Perfect. Some challenges that can occur if you have opacities within the media. Opacities cause scatter, not necessarily aberrations, but we do find that even these patients do have some improvement. So it's not a totally lost cause. More research is needed in these areas to find all the limitations. Perfect. Lens selection. This is out of Turkey. They did a great retrospective on this. They found that early keratoconus or mild keratoconus was best served with soft and hybrid lenses, whereas moderate to severe RGPs and scleral lenses. And Frank Zhang's work, how do you choose between a corneal gas perm and a scleral lens? Looking at the elevation differences between the top and the bottom of the cornea. Again, that asymmetry that we were talking about before. We can create a more symmetric corneal shape, we can thus create a less of a variation there and be more successful in gas perms. If you have less than 350 microns between the top and the bottom of the cornea in the elevation map, they showed a 88% success rate with corneal gas perms. So if you have more than that, consider a scleral lens. If you have less than that, consider your gas perm. And lens-based surgeries, if you've done those procedures to smooth out the cornea, phakic IOLs and IOLs are great options for these individuals. If you're going to go toric, though, on either an ICL or an IOL, we need to understand the goal of this, and if it's post-op, no glasses, or excuse me, no contact lenses, that needs to be determined beforehand. And nowadays it used to be a huge no for toric IOLs and contact lenses, but now with innovations in custom soft lenses, in scleral lens optics, and even just using glasses over the top with cylinder correction in it, toric IOL options are a decent option for individuals as well. So don't be totally afraid when they say that, but go from there. I think that's the last
It's a
slide.
great point for collaboration. In our clinic, we often are talking back and forth. I'm talking to the cataract surgeon and the corneal surgeon, like, what is our target? What do we want? What kind of IOL do we want? Because many of these patients with keratoconus need cataract surgery as well.
Exactly. So the important portion to leave here with tonight is that this is a collaborative effort between you and your ophthalmology colleagues. The idea here is collaboration will allow for better outcomes for everything. Cross-linking will prevent advanced disease and give them more correction options. Corneal surgery options will create less symmetry, which again will give us more visual correction options. And scleral lenses are 100% necessary for management of advanced disease, which will lead to less corneal transplants.
So excellent patient resources, NKCF. Please wish all of your patients a happy World Keratoconus Day tomorrow. Let's celebrate it. You can actually celebrate it all month long, right? NKCF has wonderful literature that you can give to your patients, refer them to the website. You can give that information. There are monthly webinars, there's a podcast, there are practice locators, and there's a lot of other resources for your patients that's really helpful. So cannot say enough great things about NKCF. So with that, we want to thank you for your time, for your attention. If you have any questions, I think we can answer a few questions here.
So what we'll do right now is, I know that we've kept you a little bit longer than about five to 10 minutes longer than we would have normally, but hopefully this was really great information for you guys to learn. And we'll go through a couple the Q&A. In the chat, we went ahead and posted the survey for the scleral, or excuse me, not the scleral, the Keratoconus Education Initiative. So this survey, please partake in it. The more we understand about clinical practice, the better the guidelines we can create in the future. So let's go ahead and you can give a couple more clicks and get to their wrap-up slides there. But in the Q&A, we'll go ahead and we'll start with a couple of these. So let's see here. Melissa, what age is considered early diagnosis for keratoconus?
I was going to say any age, but that's a whole other topic. But seriously, if there's eye exams are important for babies too, right? At 6 months of age. And so if you had a patient with keratoconus and they brought in their infant and you saw something suspicious, but typically 7, 8 years old, I'd be pretty concerned.
Yeah, I would say, if we look at the documented literature and the pediatric review study by Bala and Body, he, I think, diagnosed keratoconus in a 4-year-old, and that I think is the lowest documented age. So it can happen at that. Now, Early diagnosis doesn't necessarily just mean the age of diagnosis, it means catching the disease at its earliest state as well. So if somebody's 20 years old and is just now manifesting the disease, it's important to catch that at its earliest level. Melissa, what ethnicity? I think this is, yeah. It just says ethnicity is Middle Eastern question mark.
Yes,
So
I think that part of the point is high prevalence of keratoconus in that population.
yeah,
And
go ahead.
yes. Oh no, that's fine.
Oh, that's it. Okay, yeah, I was gonna go with basically, if you look at the Riyadh study that Emilio Neto Torres did, he found in a population in Riyadh in Saudi Arabia, a prevalence of 1 in 21. So you can see these higher isolated populations have that. You look at the RAIN study, it was 1 in 84 in that Australian cohort. If you go to New Zealand, in the Maori population, you're looking at a 1 in 191. So ethnicity plays a huge role in this, and ethnicity and genetics are not something that you can separate. They're extremely important.
And John, for our last question, I think we should answer this one, and we can probably talk about this more in detail later, but can you touch more on fitting scleral lenses on patients that have a toric IOL? Is it better to suggest that the surgeon use a monofocal in any patient that might need a scleral afterward?
Sorry, I was reading other questions when you read that one, so I didn't.
Yeah, so I'll answer this one. So it's about scleral lenses in and toric IOLs. So
Got
I think the importance here is to have a good conversation with the corneal surgeon and who's doing the cataract surgery, and really explaining. I've had many conversations explaining what a scleral lens is, because some don't know. They don't know what a scleral lens is, and the appropriate target for that patient and the goals of that patient. Do they have other conditions like dry eye and keratoconus where we want to correct that with a scleral lens? Are they wanting to eliminate a scleral lens? But we can definitely answer that question in more detail. But it's a great conversation that I have often for our patients who need cataract surgery.
Yeah, I would say, for that, it essentially depends on how, what's the level of toric that they're going to put into there. Like a -2 is pretty easily to take care of with a front surface toric on your scleral lens. A -6 is a lot harder. So, having that conversation beforehand with the surgeon is extremely important. I would say there's a question here that we definitely need to cover, which is at what age is cross-linking FDA approved? And are patients treated off-label if progression is demonstrated? The FDA-approved age range is from 14 to 65. When we look at that, that was just the range that was treated within the clinical trial. If they're younger than that, they can be treated off-label. If they can't afford care, they can do charity care for this. It's a very important thing. If they do progress, you can do cross-linking again on those individuals. What stage does retinoscopy reflex show in keratoconus? Very, very early in that study that Melissa had talked about earlier, that was a Ministry Oman study. Essentially what they found was at a level of the BAD, which is an algorithm that looks at standard deviations away from normal, at 2.6, they were able to statistically significantly predict the presence of keratoconus with retinoscopy with, I think it was over 80%. It might even be closer to 90% sensitivity and specificity. Can PRK only be done post cross-linking? We only do it either post cross-linking or concurrently in the office with cross-linking or sequentially with cross-linking. We don't do it without cross-linking. Man, I am
I think we should wrap up here.
good with wrapping up. I think I could have ran